So the purpose of this YouTube video is to get better understanding of how and why you would take a cerebrospinal fluid sample from a dog and cat, including how to interpret them. First of all, what is the cerebrospinal fluid? It's the fluid that bathes the nervous system. It's normally clear, containing inorganic ions, proteins, glucose and cells, and it has a number of functions, of which the most important is to clear waste from the brain, to distribute nutrients, to dampen shock, and to buffer pressure changes. And the CSF moves in a pulsatile manner within the brain and the spinal cord, depending on various pressures such as gravity, the systolic pulse, the pressures in the chest associated with breathing, and the distension of the epidural veins. And it maintains a very critical role in ensuring tissue homeostasis. About 40% of the cerebrospinal fluid is produced by the choroid plexus, which are little glands within the ventricular system of the brain. And this is a very complicated biochemical process, which I'm not going to go into in this lecture, but you can see from this diagram here that only represents some of the processes that there is an awful lot of metabolic pathways and ion channels involved. And these choroid plexus are within the nervous system. I'm showing them in yellow here within the lateral ventricles going into the third, and in the fourth ventricle going out of the lateral apertures. The fourth ventricle choroid plexus is the largest, about 55% of the choroid plexus volume, and so it is the most important for production of cerebrospinal fluid out of all of the choroid plexuses. The rest of the CSF, however, comes from the brain interstitial fluid, and you have to think of the fluid being kind of circulating through the whole brain, and this is what's called the glymphatic system. The CSF is also absorbed through lymphatics in the cranial nerves, especially the olfactory route, and lymphatics associated with the meninges and with the spinal nerves going down to about T1. The arachnoid granulations are also important in involving the CSF, but probably only when the CSF pressure is elevated. They were given a much higher status in CSF absorption previously. It's considered that their contribution is less now. So why might we want to analyse the CSF? Well, it is very challenging and invasive to biopsy the brain, and so analysing the fluid which bathes the brain and the spinal cord can give us important clues about the disease process that's going on inside. And it's an important diagnostic tool, usually combined with other test results, but certainly history, clinical finding, and often advanced imaging such as MRI. And that's really because CSF analysis rarely provides the definitive diagnosis. So there's very few diseases that you can diagnose with CSF analysis alone. Your standard analysis is measuring the number of nucleated cells. You also measure the number of red blood cells. Red blood cells are not normally found within the CSF, but they may be there because of iatrogenic contamination or sometimes because of bleeding. You measure the total amount of protein there, and then you look at the population of cells. And the site, usually sampling is caudal to the suspected site of the lesion, and that is because although the CSF has a pulsatile movement, it's generally thought that there's a kind of bulk flow going from rostrally to caudally. However, you may sample from two sites where you suspect inflammatory disease, because there is an increased chance of diagnostic yield, and that's particularly important for diseases like steroid-responsive meningitis arteritis, where when you take the CSF sample, in some cases, you're not necessarily always going to get a diagnostic sample. And if you're going to the effort of anaesthetizing the dog and subjecting it to a CSF sampling, then you want to maximize the chances of success. So the easiest site to obtain is from the cerebellomedullary cistern, and you do this by putting a needle between the atlas and the occipital bone or supraoccipital bone, and you need to open that space, so you flex the dog's head. It's very important to get a skilled operator helping you to position the dog, because the dog's head should be at 90 degrees and they should be horizontal to the table. And it's definitely a technique that you need to practice first, and I recommend that you obtain permission from a caregiver to practice on a dog that is recently deceased. Obviously, you should always obtain permission, but after death, a kind caregiver may permit you to practice obtaining that sample before you try on live dogs. And you can see here the placement of the needle and the fluid very gently dripping in. I'm not going to go into too much depth on how to position that needle, really because I think that this is something that should be taught practically and not for a YouTube video. So the positioning is that you put your usually one finger and one thumb on the wings of the atlas and another finger on the occipital crest, and that forms a triangle, and then you go directly in the middle of that triangle, which gives you the position of your needle, and insert the needle very gently until you feel it pop through the membrane, and then take out the stylet and you collect the fluid. Getting a lumbar sample is from the lumbar subarachnoid space is a lot more challenging. There's much more risk of blood contamination, but it is more appropriate for thoracolumbar lesions. And so if the animal has thoracolumbar disease, you really should try to obtain a sample from there, because a sample from the cisternal site may not be useful. Now, you may say, what sort of complications do you get from cerebrospinal fluid collection? And in actual fact, very, very few. And it's probably because skilled operators should be doing it. But in a recent study that looked at it, they didn't find any major complications in 102 dogs that they did this prospective study for. So, although it sounds like and it is an invasive procedure, actually in skilled hands, the complication rate is quite low. For the lumbar sample, or at least I put my fingers on the wings of the ilium. Then I know that L7 is kind of directly across from that and a little bit behind. And then L6 is just in front of L7. Obviously, the spinous process in front of L7. And then that gives me my sampling site. The cerebrospinal fluid, they say the routine analysis is that you should check its colour, and it should be colourless and clear. It's analysed for its total nucleated cell count. We look for the cells and the normal cells in the CSF and the monocytes and lymphocytes. Very rarely will you get neutrophils, and in most instances we consider having the presence of neutrophils and eosinophils as abnormal. We shouldn't have red blood cells, but it is common to get a few because of iatrogenic contamination. And the total protein is these figures here that you can see. It's slightly lower in the cisternal site. So first of all, the appearance. So when the cell count is very high, you'll have a cloudy sample, as indicated here. Now, this cell count was in the thousands, over 3,000 in fact, and you won't detect that change by visualization until the cell count is more than 100 cells per microliter. Now, if you bear in mind that the normal cell count is less than 6 cells per microliter, this means that you cannot tell that a CSF sample is abnormal by looking at it. And you may think that that's a very simplistic statement to make. Of course you can't. But certainly we used to have an issue when people were doing myelograms that people would look at the CSF and say, well, that looks okay, and not submit it for analysis. But my recommendation is, if you are in the CSF space and you take a sample of fluid, that you always have it analysed for reasons that I'm going to go into later. Iatrogenic blood contamination is relatively common, and in that instance it looks pink, as you might expect. However, if the blood has been there for some time, it starts to break down and you get this thing called xanthochromia, which has a more orange appearance. And this is samples taken from the same dog, and it shows you how different they can be in different spaces. So this was the cisternal space, and this was the lumbar space in a dog with steroid responsive meningitis arteriitis. And in that autoimmune disease, there is inflammation of the blood vessels, and you may get bleeding into the subarachnoid space. So after inspection of the CSF, you then do a cell count. And for the vast majority of people, we still use a hemocytometer, which might be regarded as a slightly old-fashioned piece of kit. But when you have something which has got very low cell counts, then this is still one of the most accurate ways of determining the number of cells. It also can be done very easily in an in-house laboratory and done very quickly, because the thing about CSF analysis is you do want to analyze that sample quickly, because, for example, you may want to know if it is likely that the dog has an inflammatory disease before you do other expensive tests such as MRI. But more importantly, the number of cells start to degenerate with time, and so getting a quick analysis is very important. And it's quite simple. You do need a little bit of skill in learning how to put the sample in and place a cover slip properly. And you simply count the number of cells in the 9 large squares like that, and that will give you the number of cells per microliter or millimeters cubed. Traditionally, it used to be talked about staining those cells with crystal violet or methylene blue. It's not necessary to do that. You can see the cells, they sort of look silvery without that. And also when you add that, that may dilute the cerebrospinal fluid. So that's not routinely done. And if we have a raised total nucleated cell count, then we call that a pleocytosis. And it's often graded. So mild would be less than 50, moderate less than 200, and severe more than 200. Next, we analyze the protein, and it's not possible to do this with a urinary dipstick. It tends to underestimate it and will overestimate glucose. It's usually necessary to send it off to an outside lab, but you may be able to do it in your inside lab depending on your analyzer. So a high protein would be greater than 30 milligrams per deciliter for the cisternal and 45 for the lumbar, as the lumbar tends to have a higher protein because of stagnation of CSF flow. It's slower down in that region. It's flowed all the way down, and so it tends to pick up more protein. And when we have an increased total protein with a normal total nucleated cell count, then we call that albuminocytological dissociation, which is also called hyperpronrachia. I think that's how you say that. That's probably the more correct term, but I have to say I never hear anybody saying that particular term. Most of us say albuminocytological dissociation. But what if you've got blood contamination? Because of course, if you've got blood contamination, which I've said as before, that will increase your amount of protein. So if you have 1,000 and that's why it's important to count the red blood cells. If you have 1,000 red blood cells per microliter, then you need to subtract 1 mg per deciliter for the measured protein concentration, and you need to subtract 1 cell per microliter for every 500 red blood cells. Most people count the red blood cells using the 5 squares as before, and they can be distinguished from the white blood cells by the fact that they look like biconcave discs, as opposed to the larger red white blood cells, which are flatter. So what diseases are associated with albuminocytology cytological dissociation. Well, basically this can happen because the blood-brain barrier is leaking. For example, in viral infections, especially distemper. This because there is increased production of protein, which is also being leaked through that leaky blood-brain barrier. So immunoglobulin, for example, having a raised CSF protein is one of the sort of classic indications of idiopathic polyradiculoneuritis or Guillain-Barré syndrome, that is in humans. You may have it because of damage to the nervous system, for example, myelin basic protein following trauma, for example, intervertebral disc disease. And you can also have it if the CSF flow is sludgy, is not moving very quickly because there's some kind of obstruction. For example, in canine Chiari malformation, it's not unusual for the CSF protein to go up. So where you have an increased protein but a normal cell count, the most common diseases that this is associated with are cranial nerve neuropathies, especially trigeminal neuralgia, for any cause of that, or Bell's palsy, facial nerve paralysis, neoplasia, idiopathic vestibular disease, again, presumably because this may involve the nerve root, acute polyradiculoneuritis, as I've said before, following an infarct, sometimes in MUO, meningoencephalomyelitis of unknown origin. They don't always have a raised cell count, following trauma such as intervertebral disc disease, and even with some cases of idiopathic epilepsy. And I really like this paper, so if you're interested in reading more about it and which are the most common diseases, then I would recommend that. Now, of course, increased protein could either be albumin that's leaking through a leaky blood-brain barrier, or it could be immunoglobulin, which is being produced as a result of inflammation. And sometimes it could be helpful to know which is which, because immunoglobulin being produced intrathecally obviously has a very different cause than leaky albumin. So there is a way of determining that, and that's called the immunoglobulin index. And this isn't done very commonly anymore, mainly because it's more difficult to measure, but sometimes wonder whether we should. And that's where you measure the globulin in the CSF and compare it to the globulin in the serum, and the same with the albumin. And if there is increased globulin in the CSF, then it's going to be a higher ratio than normal, and the normal is less than 7. You can also measure specific immunoglobulins. So steroid-responsive meningitis arteriitis is associated with increased IgA classically, although I have to say in all of the cases that I have ever measured IgA for this, I have not found that. But to be fair, this was many years ago, and after not finding it particularly useful, I stopped doing it. So it may be a very useful test for some. I would say in the UK, it's not often done because the assay takes 1 to 2 weeks, which clinically is not so useful, because in this disease you usually have had to make a decision that this is the disease and have started treatment. However, it is a biomarker of that disease, especially if you want to prove that it's that and say not bacterial meningitis. So next we need to look at the slides, and in this the cells, and in this because the CSF normally has a low cell count, you can't just put a drop of CSF on a slide and expect it to be useful unless it's incredibly cellular. So what you need to do is spin the sample down so that you get all of the cells down in a little blob on the slide. So what you need to do for that is to have a cytocentrifuge. So the way this works is you have the slide there in a clamp, and then this little chamber is put in, that the CSF goes in there, and then it's spun, and then the pellet of cells goes right the way down to the bottom where you can stain it. So you can see this is the clamp system, and then they go into the centrifuge like that, and that is the centrifuge. Now, cytocentrifuges are actually quite expensive. They're several £1,000s, so it's not necessarily something that a routine practice would have. And if you have to send them off for analysis, then if you can't analyze it that day, really within 8 hours, then it would be a good idea to add 1 drop of 10% formalin to the EDTA tube. Ideally have both EDTA tubes, as this will, 2 EDTA tubes, one without formalin, as this will improve the cell stability and is not meant to affect the protein. I love this paper. This is where they've taken the sort of system for going down onto a slide here and put it onto a salad spinner and done it manually. And this particular paper compares those results, and the study found that they were comparable. So there are ways of doing it in practice, which can be quite important because those cases don't necessarily keep laboratory hours. If you want to analyze a sample over the weekend, for example, then the lab is not going to be open. So when we look at our cytology, we expect to see a low number of cells and them to be mononuclear cells or lymphocytes. If we have, we call it a pleocytosis, if and a particular type of pleocytosis if the cell count is up, but if it to give it the name neutrophilic pleocytosis, it would have to have more than 25% neutrophils. And actually, because the neutrophil is an abnormal cell in the CSF, then we would call it a neutrophilic pleocytosis even if the cell count was normal, and that is also the case with eosinophils. Whereas mononuclear cells would have to be more than 70% mononuclear, lymphocytes the same. If it's no clear cell type, then we call it mixed. With the eosinophils, there is no clear definition. It's generally regarded as more than 25% eosinophils, like the neutrophils, would be regarded as a pleocytosis. However, it really is unusual to see eosinophils in the CSF unless there is blood contamination, and so some would regard more than 5% as being abnormal, and we call that an eosinophilic pleocytosis. So it's maybe worth checking what your individual lab will define that. So what diseases are associated with a neutrophilic pleocytosis? Well, probably the most common one that we see is steroid-responsive meningitis arteritis, and this is an autoimmune disease against some component in the blood vessel, and it's characterized by inflammation in the arteries and in the meninges, and overwhelmingly population of neutrophils unless the disease becomes chronic, and we'll go on to that later. Infectious causes, however, will also cause a neutrophilic pleocytosis, and it should be said that generally infections are less common in domestic animals, such as cats and dogs, and bacterial infection is much less common than in humans, and it is most common due to a direct extension. So what I mean is that if you have infection in an area which is close to the brain, that may spread. So otitis media, and some animals are more predisposed. French bulldogs, for example, are much more likely to have a spread from otitis media than other breeds, probably because of poor drainage and other brachycephalic conformation, or if there's something obstructing the drainage, such as a cholesteoma or a polyp. Now, when there is a bacterial infection, then the neutrophils have a more toxic and degenerate appearance, whereas in steroid-responsive meningitis arteritis, they do not look toxic and degenerate on the whole, they look healthy. And you should be able to see intracellular bacteria, as we can here. There. So you also get a neutrophilic pleocytosis associated with FIP, feline coronavirus infection, and often the protein in those is really high. And you may also see it with other infections, rickettsia, protozoa, algae, fungi. With tumours, you can get a neutrophilic pleocytosis because of sort of malacia and inflammation in many different types of tumours. Where it becomes potentially quite useful is trying to distinguish a histiocytic sarcoma from a meningioma. A histiocytic sarcoma is a much more inflammatory tumour, whereas a meningioma, it is more unusual for you to get a pleocytosis associated with it. Why would you want to tell? Well, really, if you're proposing doing brain surgery, then histiocytic sarcomas have a much worse prognosis, and so you may have subjected that animal to brain surgery when they don't have a good prognosis from that. So you may have a report of neutrophils in the CSF without there being a pleocytosis, i.e. more than 20%. And as I've said before, neutrophils are not a normal cell in the CSF. So you may see it after any trauma, so recent fibrocartilaginous embolism, acute disc extrusion, after traumatic brain injury, or with syringomyelia. With acute disc extrusion, this has been correlated with injury severity. So some people have tried to look at dogs with deep pain that are deep pain negative to try to look for prognostic factors as to whether or not they will regain function. And obviously this is important because if you go forward with surgery for these cases and they don't improve, then the owner can have a very large bill without having an outcome. And it is said that if you are deep pain negative with a large number of neutrophils and more than 13% macrophages, then this is associated with a poorer prognosis. And that cell count will become lymphocytic with time as well. So this is an acute injury. You can also see it with blood contamination, and that's quite important because a little bit of blood contamination, you may see disproportionate numbers of neutrophils for some. You can also see neutrophils after myelography, which goes back to my original point that if you are doing myelography, if you don't have MRI available, because MRI has replaced myelography in many countries, then that is why it is important to analyse that CSF sample, even if it looks normal, before you do the myelogram, or to send the sample off as you do the myelogram. Because if you take the sample after myelography, you're going to see an inflammatory tap, and so it make it very difficult to interpret. So it is better to send this sample off, even if it's not useful, than it is to miss taking the opportunity to analyse it and then to have to re-anaesthetise the dog and get a sample again. When are eosinophils seen in the CSF? Well, generally regarded as less than 5% as a non-specific finding, although you will find some texts that would regard any eosinophil as an indication of disease. But you can see the odd eosinophil if there has been some blood contamination, so be cautious at interpreting it if it's less than 5%. And I've said before, there's a little bit of disagreement as to what actually is an eosinophilic pleocytosis. Strictly more than 20%, but some people will regard it as much less than that because it's so unusual. The most common disease is eosinophilic meningoencephalomyelitis of unknown origin. It'll range between 12 to 100% eosinophils. The other most important disease is histiocytic sarcoma, and this is an example of a histiocytic sarcoma here. And I think you will agree with me that just looked at casually, this does look quite like a meningioma, except if I was to show you the T2 weighted image, you'd see that it was associated with far more edema than I would expect most meningiomas to be associated with. So an inflammatory CSF would be much more indication of a histiocytic sarcoma. The only challenge with that is that taking a CSF sample in this dog would definitely not be safe, because I think you can probably determine that there is caudal shift of this brain, and there is a herniation under the tentorium, and there's also, although you can't really see it here, but there is a foramen magnum herniation. And when you take a CSF sample when there is raised intracranial pressure, then putting the needle in causes this sudden release of pressure, and basically it worsens the herniation. I don't think it's quite true, but what we used to say is that the brain tries to come out the needle. Well, it just comes out even further. Herniation worsens, and the dog or the cat stops breathing. And this is why in many instances, especially if you suspect a brain tumour, then the CSF sample is taken after the advanced imaging because of that risk of herniation. You can also see it with other tumours, and an eosinophilic pleocytosis has been reported in all of these tumours, including, maybe quite surprisingly, a T-cell lymphoma. It's also been reported in acute intervertebral disc disease, and not just one dog either, which is quite a surprise. And it may be that those particular dogs are just more likely to have an eosinophilic inflammatory response. For example, Rottweilers are much more likely to have an eosinophilic inflammatory response in my experience. And you classically will see it with neural parasites, and it may not be a very high proportion of this eosinophils. So you may just find occasional eosinophils in the CSF when all of these infections, so Angiostrongylus, parasitic larval migrans, protozoa, bots, yeasts, algae, and you can, as I said before, occasionally see it with blood contamination, and that can be less easy to interpret if they have a low total nucleated cell count. So lymphocytic pleocytosis, the most important cause of this would be an immune-mediated CNS inflammatory disease. I've put auto there because, of course, any inflammatory disease is immune-mediated, but I mean these specific ones where there are not an infection associated with it. So meningoencephalomyelitis of unknown origin, which is also called MUO. Idiopathic generalized tremor syndrome, although those can often be normal, and they always have a very mild increase by comparison of the total nucleated cell count. Autoantibody positive encephalitis, so that for that I mean the sort of limbic encephalitis and ones where you have autoantibodies against cell surface receptors or other parts of the nervous system. And it's also been reported in ganglioradiculoneuritis. Viral diseases are the classic stimulator of lymphocytes, and in particular distemper. And this is an example of a Cavalier King Charles Spaniel that had distemper. It was imported from a puppy farm in Eastern Europe, arrived in the country with distemper most likely, and you can see the changes on the pad, which is characteristic of distemper. You can also see it with lymphoproliferative disease, i.e. Lymphoma. And that may be a surprise. You may be expecting to see lymphoma cells, cancer cells with that, but actually sometimes you will see what looks like just normal lymphocytes. So if you do see a very high proportion of lymphocytes, then for me the next step is to take a PAR, which is a PCR for antigen receptor rearrangements. And what that is looking for is it's a test for lymphocyte clonality. So it's looking for clones of lymphocytes, because when you have lymphocytes that are neoplastic, then they've all come from the same mother cells, so they're clones of each other's, whereas reactive lymphocytes are different. To get this, you do need enough cells or DNA, so sometimes you'll send it off and you'll be told, no, they can't do that. And about 7 days after an acute disc extrusion, that neutrophilic pleocytosis becomes lymphocytic. So just bear that in mind if you're taking a CSF sample from a dog that's had intervertebral disc disease, you may see those changes. So mononuclear pleocytosis, and the mononuclear cell really reflects chronicity. And so in many of the infectious diseases, these may be more chronic infections, reported in feline immunodeficiency virus, fungal infections, leishmania, protozoal. You also may see it in MUO, idiopathic generalized tremor syndrome, and actually chronic steroid responsive meningitis arteriitis. So that disease, which is neutrophilic to begin with, once it becomes chronic, and you may say, why wouldn't they get diagnosis before that? Well, actually, sometimes this disease can be only a few days, characterized by a pyrexia, taken to their GP vet. The GP vet notes the pyrexia, the animal's not well, treats with antibiotics, the animal then improves, and then usually about a month later, the whole process starts again. So it can be kind of waxing and waning, and when it goes into that chronic phase, you may find a mononuclear pleocytosis. You can often see this also with other types of neoplasias, and you can also see it in following seizures, a very slight increase in total nucleated cell count it should be, which is one of the reasons why CSF analysis can sometimes be quite frustrating and unrewarding when you're working up idiopathic epilepsy because of very non-specific changes. And this, I have to thank Nicola Parry for this slide, which is an example of GME, granulomatous meningoencephalomyelitis, which was one of the diseases covered under the meningoencephalomyelitis of unknown origin. You can make that diagnosis of GME only on pathology, which is why we know that is what this is. And this is a perivascular cuff. So you have the blood vessel here, and all of these dark blue cells are the lymphocytes and the monocytes that are coming out of the blood supply, pavementing out of the blood supply into the perivascular space, out into the meninges, and also into the brain itself. Mixed pleocytosis is very common, where you don't have a predominance of any particular type of cell, and it may be described as mixed with just mononuclear cells and lymphocytes, or it may imply a number of neutrophils or even eosinophils. So it's important to get that differentiation. Again, you're going to see that with MUOs. Chronic steroid responsive meningitis, arteritis, with some infections that go towards more chronic infections. These are the ones that are all reported. I wanted to say here osteomyelitis, presumably possibly spondylitis as well, with meningomyelitis. That's quite important. These are infections of the bone and the disc space. They don't just result in changes of the CSF space, because that space is quite distant. It has to traverse the epidural space and then cause inflammation of the meninges, which doesn't happen in every case. So CSF analysis is usually normal with osteomyelitis and discospondylitis. Again with neoplasia, and again after myelography. Sometimes you can see neoplastic cells in the CSF. Lymphoma cells, as we've got here, carcinoma cells, if there's carcinomatosis, which is where you get carcinoma spread along the meninges, and it has been reported with malignant melanoma as well. And sometimes you can see infectious agents in the CSF, which is one of the times that you can actually get a more firm diagnosis with a CSF sample alone. So you may see bacteria, you can sometimes see mycobacteria, you can rarely see protozoa, such as here. These are tachyzoites from toxoplasma, which are within a macrophage, and there's a free tachyzoite there. Rickettsia, and they are typically within morellae, which are the sort of purple cytoplasmic vacuoles filled with that infectious agent. Cryptococcus and algae have been reported. Now, if I suspect a bacterial meningitis, then I normally put the CSF into a blood culture broth. And that is because it's actually quite difficult to culture organisms from the CSF as a low number of organisms. So you increase your chance, just as you increase your chance with blood, by putting it into blood culture broth. Not everybody does that. Sometimes the labs are a bit surprised by that, but that was what I was also always taught to do. You can also test the fluid for infectious diseases using PCR or reverse transcriptase PCR for the RNA viruses. So distemper, coronavirus, protozoa, tick-borne encephalitis, only early in the infection for that one. And anaplasma are the tests that are more routinely available. We don't usually test for these routinely. We test because it's expensive. We test them really if we suspect that this might be the case. You can also do antibody titers on the CSF, and that can be quite useful to help distinguish disease from exposure. For example, with tick-borne encephalitis, Neospora and toxoplasma, many dogs will be exposed to that and will have a positive antibody titer from the serum. However, it should not have spread into their CSF space, and therefore getting an antibody titer from the CSF, if there is no blood contamination, of course, can be useful to confirm disease. Now, some of you may be wondering about other laboratory parameters that are routinely assessed in humans, but not commonly assessed in dogs. So what are those? Well, the most important one is glucose, because this is routinely assessed in humans. And that is because the glucose ratio, which is the glucose level in the cerebrospinal fluid compared to the glucose in the blood, is a biomarker for bacterial meningoencephalomyelitis. So a reduced glucose is due to bacterial consumption of the glucose and is an important indicator, kind of bedside indicator of bacterial meningitis. However, this is not the case in dogs. You can get a low glucose level, but it seems to be associated with increased cell counts, and importantly, doesn't distinguish steroid responsive meningitis from bacterial meningoencephalomyelitis. So it's often not done in veterinary medicine. There's no reason why not to do it, but it's often not done. And then we have lactate, and again, in humans, the CSF lactate is useful to discriminate bacterial meningitis. It'll be increased from aseptic meningitis. However, in dogs, it's increased in about 50% of those dogs, and there's no difference between any of the CSF inflammatory disease, including infections. So again, it's not useful. It also increases in human patients after seizures, but it seems to be minimally affected by seizures in dogs, and so it's not considered useful. However, I will measure serum lactate, and that's the normal CSF lactate, and I usually measure the serum as well, just to give a comparison. But I will measure the CSF lactate if I suspect that there is a mitochondrial disorder, and that's the normal range that is thought there. I have to say that sometimes CSF analysis can be quite frustrating, especially when we have an expectation in veterinary medicine that it be done and we know that it's likely to be low yield, or more frustratingly, give results that maybe are conflictory. So may say an albuminocytological dissociation, an increased protein, and you don't know whether or not that is because of a serious disease or just a rather benign process. And the diseases that it's most frustrating to obtain it would be for idiopathic epilepsy, which we are supposed to for tier 2 diagnosis, and for idiopathic vestibular disease, where you see no changes on the MRI, and you think it's idiopathic vestibular disease, but often the sample may have some mild changes. So what we would like really with CSF analysis is to give us more. We'd also like it to be able to tell us the difference between the different inflammatory diseases. So are there any biomarker research out there? Well, creatine kinase is a potential prognostic biomarker, and in humans, there is a correlation between the CSF creatine kinase and recovery with patients with trauma, hypoxia, meningitis. And in dogs, they've done pilot studies really only. This is the normal level of creatine kinase, and it is meant to be higher than the thoracolumbar, from the lumbar site if you have disease in the thoracolumbar area. And it has been used to look for a prognostic factor in intervertebral disc disease. As I said before, it would be nice to know before the dog gets myelomalacia if the dog is going to get myelomalacia, or if the dog is not going to recover. And this is an example of a dog that went on to develop myelomalacia. We can see the high signal in the cord here. And so they actually took a cisternal sample of CSF in these studies, down here, which is useful to know because sometimes when you get a lumbar sample, try to get a lumbar sample in these dogs because of the swelling of the spinal cord, you may not get a lot of CSF. So this is a cisternal sample, which is easier to take. And they found that in normal instances, the myelin basic protein was less than 3 nanograms per milliliter, and the creatinine kinase was less than 38. And that when you had this figure, then the long-term functional recovery was more than 98% for dogs with disc disease, regardless of their initial neurological status. So actually one would argue that if you could get this test quickly, then that would be a good indication to the owner about whether their dog was going to get better. Because as we know, if you do spinal surgery, what the owner wants to know is if they go forward with their spinal surgery, will the dog get better? Will it be worth it for the dog and the owner? What we'd also really like to have is the markers of immune-mediated diseases and the autoimmune encephalitis, which is really a sort of area which there is a lot more tests for in humans. There is a population of dogs that have refractory epilepsy that probably have some kind of autoimmune process. And trying to identify those would be very useful. So there's been some studies that have looked at oleoclonal bands, which are strong but non-specific markers of chronic CNS inflammation. And there are a few studies out there looking at the neural autoantibodies. So these are the antibodies against cell surface receptors and things like the potassium channel and myelin basic protein for diagnosis of these autoimmune encephalitis, in particular limbic encephalitis. As I've said before, there's quite a few studies which we'd like to have for steroid-responsive meningitis arteriitis to be able to confirm that neutrophilic pleocytosis is something that should be treated with steroids, which would obviously be a bad thing to give to cases with infection. And they've looked at microRNA and as I've said before, IgA. And then with MUO and meningoencephalomyelitis of unknown origin, there are tests for the antiglial fibrillary acidic protein in pug dogs, for pug encephalitis, oleoclonal bands again, and various different CSF protein biomarkers, which I've listed there. And the same goes for canine idiopathic generalized tremor syndrome. And that's really because actually we'd quite like to know what the target is in that disease. In idiopathic epilepsy, there have been various different studies looking at the proteome profile, metabolites, both lipid and very complex ones, which you can see the results of there. And one disease that would be nice to have a more confirmatory test would be cognitive decline, or the dog equivalent of dementia or Alzheimer's, and it is possible to measure amyloid beta oligomers, but it's not routinely done. So in summary, CSF analysis is for many neurological diseases an essential part of the workup. But for some diseases, especially for idiopathic epilepsy or vestibular disease, it's rarely useful. And I feel personally I'd like to have more in there. I'd like to have a spectrum of tests that would be useful against, say, the autoimmune encephalitises for the idiopathic epilepsy, and maybe we'll see that in the future. I'd also like to, so we want more biomarkers for these. I'd like to distinguish between the different CNS inflammatory diseases. I'd like to be able to tell when there's infectious and non-infectious disease. I'd like to be able to determine the prognosis before expensive treatment. And it would be nice to know about targets for therapy. So very useful test, but I think it's kind of watch this space. It will be, there'll be more that we can get out of this very vital fluid. Thank you very much for listening.